Now, another thing that hemorrhagic clot can do as it's evolving is it can form these reticulated appearing masses, and I think Eclipse says it better than me, where these lines are avascular. And the point I want to emphasize is your terminology. This S word, or septation, I think should be avoided if possible, because clinicians see something or read something in their report that says the word septation, there is a knee-jerk that they would suggest that that represents a tumor, because tumors are often septated. So I would urge you not to use that word if possible. There are many other adjectives and descriptive terms you can use, such as it's a reticulated process. It is sponge-like. Perhaps consider the word cobweb in appearance, but if you're going to use the word septation, say they're fine. You might want to say they're fine linear echoes, as opposed to septation, to avoid the word septation in your report, which could be confusing to a clinician. So now we've talked about the varying and common non-neoplastic cystic conditions. I'd like to talk about two others before we turn our attention to neoplasm. What about ovarian torsion? Well, as the name implies, it's a twisting of an ovarian pedicle, and often there are tumors or cystic structures within that ovary to predispose to the twist. Similar to testicular torsion, these occur in young women. And some of these women may have loose ligaments that predispose them to twist. Now, there are many ultrasound features that have been published, but I would like to emphasize the two that I think are very important and go hand in hand is an enlarged ovary in an unusual location. I would like to suggest that I have never seen a normal size and appearing ovary that is actively torsed, because that doesn't seem to occur. Also, you might consider looking for the twisted pedicle that's involved with the torsion, and consider what the blood flow looks like. We will address these. So when I'm dealing with a patient who I'm considering the possibility of torsion, let's look at a couple of examples. These are both transabdominal scans. Notice each have a mass in the midline located very unusually anterior to the uterus. That is not the location where an ovary should be located. I'm not saying it never can be, but this is distinctly unusual. And in a woman who has pain over this enlarged ovary, clearly both have masses, located in this location, I would be very concerned about a torsion. And indeed, in these two situations, these were torsed ovaries located anterior to the uterus. But you can also torse and end up deep in the pelvis in a location posterior to the uterus, and if not, in the contralateral adnexa. As we see in this patient, whose left ovary on a vaginal scan is going behind the uterus into the right adnexa. Notice a leading edge with a cyst. In this case, both ovaries are located to the same side of the uterus. They're both on the right side with respect to the uterus. Very unusual, and this case also had a leading edge, and these ovaries were tender, unusually located deep in the pelvis, and therefore very compatible with a torsion. Now, the pedicle that leads or feeds its blood supply to the ovary, there are two sources of blood flow to the ovary, unlike a man who only has a single testicular artery. There's the ovarian artery here and a branch of the uterine artery here. So the ovary having a dual blood supply, you can imagine you could torse one of these blood supplies and maintain flow to the ovary from the opposite ovarian vessel that's feeding the ovary. So it's important to recognize that, point number one, the dual blood supply. Point number two, these normal pedicles that feed the ovary are straight. We see that nicely in this case because we have fluid around the pedicle. So typically a pedicle in either side should be straight. When you have a torsion, as the name implies, you will twist the pedicle, and this has been termed the whirlpool sign. So either of these could twist with a torsion. And what they look like through a laparoscope is a twist, or, as we affectionately like to note, a whirlpool based on the ultrasound appearance. So look for the torsed pedicle. And here we have a case where on the grayscale clip you can see it looks like a whirlpool, a twist. And there's the leading edge to the ovary here that's twisted. If I just do a steady state, not moving the probe on my clip, you can see there is blood flow in here, and it looks like a whirlpool or twist. Very important to look for that, and if you see it, you can make the diagnosis of a torsion. Don't think the CT added a whole lot. Now here's a challenge case. This lady comes in with an enlarged ovary located deep in the cul-de-sac, and it was tender. And by the way, you often will get a history of when women will torse, they will give you a history, just like a man does, that they have had intermittent torsion, and subsequently, when they come into the ER, the pain becomes overwhelming. And so intermittent pain is not uncommon because I think many of these people have a lax ligament that allows their ovary to intermittently twist. When they come in with a severe pain, by the way, they're often vomiting, and that seems to go hand in hand with torsion. That's been published as one of the clinical appearances that people have when they torse. So what's interesting to me about this case is notice there is both arterial and venous blood flow. Now, it's been said that when women torse, the ovary swells and you cut off the venous blood supply. So in this case, you can see arterial and venous blood flow. So what did we do in this situation? Well, I couldn't ignore her history of intermittent pain, and now it's much worse. Her ovary was tender, and when I looked in her pelvis, I knew this was deep in the cul-de-sac. I was worried. So I got on the phone and I called the clinician and I said, I think this woman has torsed her ovary, even though there's good blood flow. And I urged the surgeon to bring the patient to the OR sooner rather than later, because if the torsion got any tighter, she might cut off the blood supply to that ovary and it might necrose. And the surgeon was so gratified when he went to the OR and saw that this was a viable ovary. That's very important. Obviously, by the time it's necrotic and dead, there's nothing you can do but take it out. So here's another case that's an important challenge case. We see the left ovary is slightly bigger than the right. The follicles are smaller. They're being pushed to the periphery of the ovary, and this woman is tender over that left ovary. All worrisome for an acute ovarian torsion. Furthermore, when we look transabdominally, we realize that the ovary is in an unusual location deep in her cul-de-sac. So far, everything is great in line for an acute torsion of the ovary. If you look at the clip here, it looks like there's a pedicle that may be torsing, at least to a certain degree. The ovary is large and swollen. But when we put color on here, notice there is hyperemia to that ovary. Certainly not lack of flow, but increased flow. So the question is, why is the flow so hyperemic? Well, as we mentioned, ovaries can torse and then they can detorse. And in the process of detorsing, also known as mistorsion, you can suddenly have a period of hyperemia that's transient. And if you can see it like this, you can suggest this ovary has just detorsed. So what should happen clinically to a patient like this? It's very important to get this woman to the operating room because she's going to be at risk to torse again. Take her to the operating room and just do a pexy, if you will, or tack the ovary down so she will not have the ominous complication of a subsequent torsion. And certainly you might want to look at the other ovary as well, because often these lax ligaments are bilateral. Now, what about women who have these multiple small echogenic foci, typically at the periphery of the ovary, as a dotted or even a very linear appearance in this more dramatic example? Do you worry or not worry when you see this? We certainly know that if we see these little echogenic foci and you're dealing in a testicle, you would be labeled as having testicular microlithiasis, and there has clearly been a reported association of this with testicular neoplasm. So is the same thing true in a woman who has these little microliths? These are small, non-shadowing, and as we said, about 95% are in the periphery of the ovary. So you recognize them, and I will quickly tell you not to worry about these. A study came out of the Brigham Hospital. Rusty Brown, one of my colleagues, took ovaries like this, and when they were going to be removed, we had the opportunity to look at these ovaries vis-a-vis the pathologic specimen, and so you can see this little tiny calcification in association with the small peripheral cyst. These are called inclusion cysts, which are things that happen after ovulation. So it's sort of a remnant of prior ovulation. Here's a very dramatic example again. It looks like a rim calcification, can even be seen on a CT scan, and at pathology we can see hundreds and hundreds of these little cysts with these echogenic foci representing the microcalcification. So this is a condition where it's not something we need to worry about. Most commonly, these are calcifications associated with inclusion cysts or prior ovulation. There have been other conditions, not as common, but we do not worry about these because these are not pre-malignant lesions. And I would suggest if you do put this in the report, and there's a question whether you need to, but if you do, please be clear in the report to say this is not a worrisome finding. Now, sometimes these little calcifications can get bigger. We followed them actually up to 13 millimeters, and only one of these cases went to surgery, and that proved to be a corpora albicans, or basically a scar in the ovary due to a prior ovulation. And a report was published based on these cases. There were 28 cases. The bottom line is these do not change with time, and therefore we do not worry about them. There's no mass associated with them, so these are not dermoids. And if you see such a finding, if you want to follow it maybe for a year, and then don't worry about it, because this is not going to be we're worried about cancer.